Recording in progress.
Christina, the speakers had the Zoom link, right? Christina?
Yes.
No, they had the Zoom link, right? The speakers.
You know what? Let's make sure that they do.
Yeah. Let me. Oh, here we go. She said, "Oh yeah, they don't have the link. Let me send it to them." Hold on one second. They're gonna come on right now. Let me just send them the link. I thought I had forwarded the invite then.
I thought their invitation had the link on it, but I could
Yeah,
be.
I think it did, but I don't know if maybe it wasn't clear.
Oh, okay. Okay.
All right, guys, we'll get started in just a sec. There we go. All right, why don't we give it just another minute and then we can go ahead and get started. Sorry about that.
Natasha, do we have a CME code?
Yeah, I'll re-put it in.
Thank you. Thanks so much.
Thanks, Jeannie. Yeah, that's a problem with Zoom is, again, whenever you log on, you can't see what happened in the chat before you logged on, which I think is silly, but obviously I'm not a Zoom CEO and no one really cares what I think about it. So. All right, we'll give it one more minute and I'll go ahead and introduce our speakers who are kindly joining us in the midst of clinic, which I think is a testament to their clinical passion. All right. All right, and Ulrike, Maaza, we record these and post them on a CFAR YouTube channel. Is it okay if we record this, or is that fine? Let me unmute you guys. All right. Is it okay if we record?
Yes, no problem.
Perfect. All right. Well, why don't we go ahead and get started because we have a nice quorum here. So I'm very excited to have our speakers today discuss anal cancer and updates in anal dysplasia. I think all of us providers in clinic are aware of how much of a rising problem this continues to be, specifically for our patient population. And I think all of us probably remember the days where it was nigh impossible to have someone who had an abnormal anal pap be able to be seen because just of a lack of clinical providers in the area. And so we're very, very lucky that in the last few years we've had Sandy Fang, and now we have a wonderful group of people that I'm going to discuss who are running an HRA clinic at Greenspring Station, which I've already had great success getting patients seen there, and it's been really wonderful. So today our speakers are Maaza Abdi, Ulrike Buchwald, and Bridget Morris, who together work, as I was mentioning, at the Greenspring HRA clinic, and they're going to provide us with an update on anal dysplasia screening. So thanks so much for joining us, especially while you're in clinic.
No problem, Natasha. So I'm going to give the majority of the talk, and then Ricky and Bridget will join us at the end for questions. So my name is Maaza Abdi. I'm a gastroenterologist and one of the partners in the anal cancer screening clinic at Greenspring Station, and it's my pleasure to talk about anal cancer, early detection, and approach to management. I have no disclosures, but I do want to acknowledge Dr. Buchwald for all of her support, patience, and guidance in training me for high-resolution anoscopy. The objectives for today are to review current recommendations for anal cancer screening, the management of anal dysplasia, and talk about our anal cancer screening clinic.
Maaza, is it right now the view is of your whole window, including the web browser?
Sure, I'm sorry.
It's perfect. Yes, that's perfect.
It's just a little bit of a lag on my
Yeah,
end.
I know.
So,
It's the way.
can you see?
No,
Or
I think it's
black
not
screen.
Yeah, it's a black screen. Sometimes if you download it and then launch it as a PowerPoint, it is a little faster. But I don't know, it's not doing it as a slideshow.
Okay.
There we go.
Oh, is it still in the auto mode?
It is, but that's okay. I think we can all see it pretty well.
Okay, I'm sorry about that.
No, thanks.
First, I wanted to quickly discuss last terminology. And so there is a two-tiered nomenclature that's recommended for squamous intraepithelial lesions, low-grade SIL and high-grade SIL. For AIN grade 1, that's under low-grade dysplasia. And for AIN 2 and 3, it falls under high-grade dysplasia. And the increase in grade corresponds to cancer risk. According to the American Cancer Society in 2021, there'll be 9,000 new cases of anal squamous cell cancer this year. The incidence has increased 40 to 50-fold in high-risk populations, and HSIL is a precursor to the development of cancer. The prevalence of HPV infection is 90% in HSIL and approaches 100% in squamous cell anal cancers. There's a sharp rise in African American men with HIV born between 1971 and 1986. And there's also an increased incidence in women over the age of 50. A Danish cohort study also showed that renal transplant recipients have a higher risk of anal genital premalignancies and cancer. Risk factors for anal cancer include persistent HPV infection, subtypes 16 and 18, history of vulvar, vaginal, and cervical cancers, prior history of anogenital warts, tobacco use, multiple lifetime sexual partners, history of receptive anal intercourse, immunosuppressive states, and HIV infection with low CD4 nadir and high HIV viral load. I also wanted to bring to your attention that women living with HIV have an increased risk of anal cancer. There is a study by Clark et al. This year looking in Texas at the veterans population, and women living with HIV have an increased risk of HPV-related genital cancers and barriers to healthcare. The incidence ratio of new lower genital cancers was higher during the study, and women living with HIV had a 1.5 increase of anal cancer compared to HIV negative controls. Anal cancer has the fourth highest incidence of cancers in HIV infection. It's fourth to non-Hodgkin's lymphoma, lung cancer, Kaposi's sarcoma. I wanted to show some newer data looking at cancer deaths in HIV. And this is a more recent study from Horner in 2021 at the NIH looking at cancer deaths in HIV to see if the rate has decreased over the years. And although cancer deaths in HIV has overall decreased, it still remains high. Non-AIDS defining cancers contributed to the largest fraction of deaths than AIDS defining cancers. And individuals that attributed to the most deaths were those with non-Hodgkin's lymphoma, lung cancer, Kaposi's sarcoma, liver cancer, and anal cancer with a population attributable fraction of 0.6%. I would be remiss without discussing prevention of anal cancer and other HPV-related diseases. And so Gardasil, a 9-valent immunization that prevents HPV, Subtypes 16 and 18 are responsible for most HPV-related cancers. It's indicated for men and women between the ages of 9 to 26, people living with HIV also between the ages of 9 to 26. Unvaccinated men and women 27 to 45 years old can speak to their primary care physicians, and it's not approved for the treatment of HPV. So who should be screened for anal cancer? We believe that patients with persisting HPV infection, MSN or history of anal receptive intercourse, men and women living with HIV, women with abnormal cervical cytologies or pap smears, history of vulvovaginal and cervical cancers, anogenital warts, multiple lifetime partners, and immunosuppressed states. Now I wanted to move forward to discussing guidelines for anal cancer screening. And there are two national recommendations, one from the New York State Department of Health and AIDS Institute that was republished in 2020, and the IDSA Primary Care Guidelines for Persons with HIV that was also updated in 2020. And for the guidelines for people living with HIV that are greater than 35 years of age, primary care providers should inquire about anal symptoms, inspect the perianal region, and make a shared decision regarding anal cytology and digital rectal examination. For patients less than 35 years of age, you should evaluate if patients have symptoms or signs that suggest anal dysplasia with cytology and possibly high-resolution anoscopy. All patients should be offered vaccination, and tobacco cessation should be discussed. And lastly, for the New York Department of Health clinical guidelines, patients should be referred for high-resolution anoscopy with biopsy if they have any abnormal anal cytology. Patients with suspected anal cancer should be referred to an experienced specialist, and more specifically, a colorectal surgeon. The IDSA guidelines are a little bit more brief, but the recommendations are for pap smears and possible high-resolution anoscopy for patients who have a history of receptive anal intercourse, abnormal cervical pap test, and genital warts. And also patients should be offered immunization. I also wanted to discuss anal dysplasia in women. Although abnormal cervical cytology is a risk factor for abnormal anal cytology, women may have anal dysplasia without having coexisting cervical disease. Therefore, women with HIV should be over the age of 35, should be screened for anal cancers regardless of their cervical pap status. And Michael Geisa in 2017 published an article looking at women with HIV who did not meet the two society guidelines that we discussed, but were found to have HSIL on their high-resolution anoscopy with biopsy. To date, there's no proven evidence that treating early precancerous lesions will reduce the incidence of anal cancers. There is an ongoing study, the ANCHOR study, and Joel Polewski gave some updates at our last EANS meetings in January. Just for a refresher, the goal of the study is to determine if treatment for HSIL decreases anal cancer incidence. They also are going to look at quality of life with screening and treatment for HSIL, in addition to collecting biospecimens. And patients that are eligible for the study are greater than 35 years of age, living with HIV, have biopsy-proven HSIL, no prior history of anal cancer, and vaccination is allowed, and previous history of HSIL treatment as long as it was further out than 6 months prior to the study. And for the schema, so all patients undergo HRA and have biopsy-proven HSIL. They're enrolled and randomized into the study, either into the active monitoring arm, which every 6 months does digital rectal examination, high-resolution anoscopy with biopsy, and obtains biospecimens, or they're randomized to the treatment arm, so that every 6 months they undergo digital rectal examination, high-resolution anoscopy, and medical and ablative therapies for HSIL. And so the outcome is to look at the development of cancer over a 5-year time period. And currently they are at 80% of their target enrollment. Next, I wanted to discuss some screening modalities for anal cancer screening. Those include the anal pap test, digital rectal examination, and for patients with abnormal cytology or digital rectal examination, high-resolution anoscopy. The sensitivity I listed for pap smear is 60 to 90%, so there is some variability with a lower specificity of 32 to 59%. And for HRA, there is it depends on your equipment and also on the provider, but the sensitivity overall is anywhere between 59 to 100% with a specificity of 64 to 74%. Before we talk about digital rectal examination, I just wanted to briefly go over the, sorry about that. I wanted to briefly go over the anatomy. So this is the anal verge with the stratified squamous epithelium, a dentate line with transitional zone, and anorectal line with the columnar epithelium of the rectum. And so lesions tend to develop in the transitional zone 2 centimeters proximal to the anal verge. For anal cytology, just for a quick review, nothing is inserted into the rectum 24 hours prior. A Dacron swab is moistened with water, inserted 5 centimeters into the rectum, so it's twirled around the walls 360 degrees as it's being withdrawn, and then processed on either a slide or for us in clinic liquid media. And then after that, you perform the DARE so that you don't get any false negative results. The EAN Society also has guidelines for the practice of the digital rectal examination. And just for a quick review, findings on your examination can include cancers which feel like hard irregular lumps, areas of tenderness, ulceration, and sometimes bleeding. In earlier, smaller stage cancers, you may just feel some subtle thickening or nodularity to the wall. Warts are more mobile, small, and softer in texture. Thrombosed external hemorrhoids are usually palpable, visible, and painful. Internal hemorrhoids may or may not be palpable and are not always painful. And then the anal papillae can be felt on the digital rectal examination, and the columns of Morgagni will disappear when you're rolling your finger. And the last thing to remember is that if a patient has rectal pain during your examination, you have a few options. You can wait and repeat the digital rectal examination, refer to colorectal surgery. They could consider examination under anesthesia. If you have the capability to do a quick anoscope, you can do that. Refer to high-resolution anoscopy clinic, and always remember to examine the inguinal lymph nodes for malignancy. And if there's a suspicious mass, you want to urgently referral to colorectal surgery. I wanted to touch upon high-resolution anoscopy. In our clinic, we actually had a change in our equipment over the last year. We were using ProctorStation, but didn't have as good visualization. And so about 6 months ago, we actually purchased a new colposcope. So there's actually 2 in the institution. So we have a Xyler colposcope. In addition, Dr. Buchwald is training myself and Bridget Morris, and we'll be done our training in the fall. So the number of providers will triple. And so come September, you'll have 3 providers for high-resolution anoscopy at Green Spring, and we're thinking about also having Ricky go down to Jayhawk Clinic. We're also working on our procedural template so that they'll be fully integrated into Epic. And so going back to high-resolution anoscopy, the anoscope is inserted into the anal canal. The colposcope magnifies the walls of the anus 10 to 40 fold. Acetic acid and Lugol's are used to visualize dysplastic lesions, and biopsies can be taken of any suspicious area. And I just showed some representative samples of L-sil and H-sil. So the top photo is one of our ProctorStation patients with L-sil. You can see a little bit of a raised warty verrucous lesion. The second picture is of H-sil on high-resolution anoscopy. On the left-hand side, this is the acetic acid stain. On the right-hand side is Lugol stain. The iodine stain is actually weakly positive, and the aceto-white is positive. So for aceto-white staining, it looks for disruption in the nuclear proteins, and so abnormal cells will uptake the acetic acid and appear white. And this is a typical lesion for HSIL. It's well circumscribed, slightly raised, and has a coarse mosaic pattern. And then this is actually a weakly positive Lugol stain. Lugol stains glycogen in cells, and so tissues that are normal have an avid uptake of glycogen. And so for patients with dysplastic lesions, and this is an area here, this small area of avid uptake and normal tissue. So areas with no uptake, or in this case, partial uptake, are more indicative of an HSIL lesion. And then this is just histopathology with immunostaining showing disarray in the epithelium, a change in the nucleus and cytoplasm ratio that even I can see, and positive P16 staining, which is indicative for HSIL. P16 is one of the tumor suppressor proteins. So for our proposed screening algorithm for patients who undergo cytology, of course, if it's normal, you can just refer them for their annual PAP exam. If it's abnormal, whether it's ASCUS, ASC-H, LSIL, or HSIL, should all be referred to high-resolution anoscopy clinic for a biopsy. For patients who have AIN1, routinely we follow them with annual HRA. If they have multiple low-grade lesions over many years, we might consider just doing pap smears and not aggressively monitoring with HRA. And for patients with high-grade lesions, AIN2 or 3, we provide treatment options. And we're actually starting to treat HSIL lesions in our clinic too. Since I'm a gastroenterologist, I actually want to combine endoscopy and give that as an option for patients. We're also going to be providing therapy in our clinic. And we have, we'll talk at the end about some of the other members of our team, but we also have a new surgeon who'll be joining in a couple of months. And so for patients who have AIN2 or 3 that are treated either with medical or ablative therapies, we usually follow them up in clinic within 6 months and repeat the high-resolution anoscopy. Other testing that we actually have arranged for with pathology is HPV typing. And so Swanson in 2021 studied 64 patients over the age of 35 with moderate risk. So it was only a small percentage of patients with HIV, about 18% if I remember correctly, and they underwent HRA, PAP, and HPV testing. And HPV testing combined with cytology increased the sensitivity of detecting HSIL compared to cytology alone. I also wanted to just review one other recent study looking into HPV typing. And so combined anal cytology and HPV testing increased specificity of atypical lesions. IDELA in 2021 retrospectively studied 139 patients with ASCUS or ASC-H to see if those patients had any squamous intraepithelial lesions. And for the ASCUS cases, 70% had a positive HPV DNA test and 51% had LSIL or HSIL. For the patients with ASC-H, high-grade cells that are that they couldn't exclude, 100% of those patients had a positive high-risk DNA, and 50% of the patients had squamous intraepithelial lesion. Last, I wanted to talk about a new alternative for patients with barriers to care, which is, and especially during COVID-2, which is point of care testing. And so one of the studies that I found from 2021 looked in Zimbabwe at self-collecting anal swabs for HPV DNA testing. So 300 women in Zimbabwe, 50% of which had HIV, with a median age of 39, self-collected anal swabs. Those were compared to clinician collected anal swabs. For the HPV For the HPV genotype, it was detected in about 25% in both arms in the self-collected and clinician-collected arms. The genotypes were actually interesting. 56 and 68 are high-risk strains for the development of anogenital cancers, but 62, 70, 44 are more indeterminate. But there was a moderate agreement between the DNA collections, whether a patient did it compared to a clinician. Now I wanted to move on to more detailed talk about management of anal dysplasia. So we'll first start with a low-grade AIN1. So most patients we just monitor with HRA, not 6 months, and every 12 months. And like I said, they can return to anal cytology if they've had multiple low-grade pathologies on subsequent biopsies. And treatments for patients who have symptomatic discrete lesions or bleeding, itching, and burning include imiquimod. So for the management of high-grade dysplasia, AN2 and 3, first I wanted to talk about medical therapy. So that includes trichloroacetic acid, which can be administered in clinic. We don't have the capability to provide that topically. But there are 2 patient preparations that we're using a lot. Topical 5-fluorouracil applied BID for 16 weeks, and then imiquimod for 16 weeks, given 3 times a week. The trichloroacetic acid is less well tolerated by patients, a little bit more burning and discomfort. But all of them can be used to treat more diffuse lesions. Next, I wanted to move on to some of the ablative therapies for high-grade dysplasia, AIN2 and 3. So those treatment options include infrared coagulation, which we do offer, electrocautery, which we also offer, radiofrequency ablation, which we don't. Cryotherapy is, we're thinking of doing a clinical trial using endoscopy and cryotherapy in the future. Of course, there's surgical options for excision of lesions. So first I wanted to discuss infrared coagulation, which is FDA approved. And so Goldstone in 2019 studied IRC versus control for treating patients with HSIL. And IRC ablation resulted in more clearance and more HSIL-free disease at 12 months compared to control. Next, we're also offering electrocautery, either in the endoscopy suite or in the office. Although the efficacy for electrocautery is pretty high, 66% at clearing that index HSIL lesion, the recurrence rate is high. And so this study by Geisa in 2020 focused on looking retrospectively at recurrence of disease after treatment with electrocautery. 88% of the patients were MSN, median age 45, and 49% had multiple index HSIL lesions. And the results were that there was a high recurrence at the 1-year mark after electrocautery therapy with a 45% local recurrence, 60% overall recurrence, and no cancer. And also remember, of course, for the patients, they are higher risk, HIV positive, and those patients have more of a risk of having persistent having persistent lesions, persisting infections with HPV, and multiple lesions at the time of procedure. And so the risk factors for local recurrence were cigarette smoking, HIV viremia, and having multiple HSIL lesions at that index procedure. Also persistence and baseline infections with HPV 16 and 18 were significantly associated with local and overall recurrence. Lastly, I just wanted to touch upon cryotherapy. This is looking at the American Journal of Dermatology. I'm using cryotherapy, and they actually do have a nice H-cell lesion here. There's a change in the vascular pattern in this area, and some just coarse punctations, and that's treated with cryotherapy. In this study, 60% of patients responded to treatment. 8% had a recurrence of H-cell, and 48% of patients did have pain or minor bleeding. Since I am a gastroenterologist, I did want to talk about new treatments offering endoscopic options for detection of anal dysplasia. So Michelle Inkster at Cleveland Clinic has been studying this for over 5 years. And so she had a publication that looked at 60 patients who came to clinic with known risk factors for anal dysplasia, who had abnormal cytologies, and they underwent high definition endoscopy using a gastroscope, narrowband imaging, which filters out lights so that you have more blue and green to highlight dysplastic tissue. And they also used chromoendoscopy, sort of the way we do in clinic here with acetic acid staining. And then they took target biopsies from lesions in 58 out of 60 patients. 2, they were not able to identify the lesion during endoscopy. But the histopathology did show low-grade or squamous cell lesions in 80% of patients. And this is a beautiful picture of chromoendoscopy and narrowband imaging with a raised lesion, increased vascularity. That's H-cell. So in summary, for difficulties of managing H-cell, the treatment is not curative for HPV infection. Patients can have multifocal lesions. It is more difficult than I imagined, actually, to examine the anal mucosa properly. It's very easy to miss lesions. Treatment options aren't standardized and are limited. Patients have to buy into doing high-resolution anoscopy. There's a high recurrence rate, and the impact on outcome for anal cancers has still not been delineated. So in summary, the incidence of anal squamous cell cancer is increasing. Prevention of anal squamous cell cancer is possible with HPV vaccine. Screening may decrease incidence and mortality of anal squamous cell cancers, and the best management modalities for pre-malignant lesions remain uncertain. I did also want to quickly talk about our clinic. The Johns Hopkins Anal Cancer Screening Center was opened in October 2019. There was a partnership with Joyce Jones to recruit Ricky here with Sandy Feng. So Ricky, myself, and Bridget are the providers at Green Spring Station, and one of our goals is to expand anal cytology and high-resolution anoscopy services to patients in Baltimore and establish best practices for the management of anal dysplasia through research and innovation. So we perform high-resolution anoscopy, anal cytology, and HPV testing, and we offer medical, ablative, and endoscopic therapies, in addition to, with our other colleagues, surgical treatments for H-cell and cancers. Just showing the providers here, myself, Bridget, and Ricky. Sandy Feng has actually been here for almost 10 years providing HRA services, but unfortunately she's going to be moving on to Oregon Health Systems, but Dr. Shadi Atala is actually going to be taking over for surgical treatment for cancers and high-grade dysplasia. We're an interdisciplinary multi-provider team, one of the few in the country, and we collaborate with infectious disease, transplant surgery, and pathology, and our goal is to become a center of excellence. Joyce, Ricky, and Sandy formed a regional consortium for anal cancer. It's a monthly conference that provides clinical updates. The conference is actually now posted online, multiple institutions, multi-state involvement, and we also have a Twitter page. We're also interested in collaborative research, and so some of the areas that we are working on, we've already have an anal cancer registry for our dysplasia patients. We also want to identify biomarkers for disease and cancer. We're also working on HPV testing and immunosuppression. And we've started a survey looking at screening for anogenital premalignancies and transplant recipients. One of the other areas of my interest are new treatments for HCell, and Bridget is also working on a training curriculum. I just wanted to make sure you guys know about a survey that we'll be sending out that looks into anal cancer screening practices in transplant populations, because there are a few guidelines that address screening. And so the goal is to better understand the practices for anal cancer and dysplasia screening across the United States. And the questions involve finding out if patients, if institutions have the HOPE Act, what their pre-transplant screening protocols are, what their education and understanding are about policy and guidelines, if they provide anal cancer screening, and any barriers to care. I also just submitted a small grant for looking at DNA methylation markers to identify precancerous lesions in anal squamous cell cancers. And the goal is to see if there are DNA methylation markers that can identify precancerous lesions and anal cancer, in the hopes that it can be combined with cytology, HPV, DNA, high-risk DNA testing, and HRA to better risk stratify patients and to determine who will progress from AIN2 to AIN3 or AIN3 to cancers. And for how to schedule appointment, Darlene Brown is our wonderful patient service coordinator. So I have included, she's very responsive. And so she's working on making sure that all of our patients are seen in clinic within 1 month. That's her email address and phone number. Thank you very much.
Thank you so much for that fantastic overview. And I'm excited that we actually, normally we don't have any time for questions. So I'm really happy that, that we do, because I think this, as you noted, this is such an important topic for our patient population. I'll just start one question. So I had been using the EPIC referral. Maaza, should we not use the what's in EPIC as an order? Should we contact Darlene directly?
I would contact Darlene.
Okay.
I don't know if she's going through any EPIC queues. So it's best to contact Darlene. You can email myself. I'm Abdi1, Ricky, Bridget, or Darlene. Yeah, and oh yes, I have been getting the HRA orders for sure. You should also put in the HRA order, but I haven't had any issues with that. I do think the best way is not to go through EPIC. But that's a good point, Natasha, that we can address. I know even Joyce and Ricky and I were talking about EPIC reminders for HRA screening too. So maybe I'll work on the EPIC reminders, and then also if we can use that to bring patients into clinic too. It is easier sometimes to just order it instead of sending that extra email over to our clinic.
So I was going to say, I feel like your group has done a great job of catching the orders on the back end. So that's when we last met, and if this has changed, then we should re-examine the workflow. But my understanding was if we put the order in, then your PSC is looking at the work queue and contacting patients. And I've had great success.
I haven't had any difficulty.
So if we need to reevaluate that, we certainly can.
See, I've had folks where I just put in the EPIC order because I didn't realize, and they've gotten to clinic.
Yeah, I think it works. And if it doesn't, then just contact us. I think though, one thing that we are not sure. Maaza was mentioning the reminders. I think one thing that is sometimes difficult is the surveillance when people come back, and we don't have an easy system. We keep kind of track of the patient and when they can should come back. But as the clinic population grows, that just doing that manually, I don't know entirely, how feasible that is. Usually we put obviously in the notes a recommendation, refer back in a year. But I also don't know from your end what do you think about how that works, or whether that patients fall, kind of through the cracks when they're supposed to come back. What are your thoughts on that, Joyce and Natasha?
Yeah, I guess I treat it like a colonoscopy, that, your direct recommendation about what the surveillance or follow-up should be is very helpful. And then as part of my care, I'm reviewing, all of their health issues.
Okay.
If they're due for follow-up, then I'll put that referral in. I think, first of all, fantastic presentation, Maaza. It's really
Thanks,
exciting.
Ricky, for all your help.
What's that? What'd you say?
Thanks, Ricky, for all your help.
No, it's just amazing. I don't remember how many years ago, Ricky, that we first met you, but Sandy Fang has been a tremendous leader in this work and had put out a survey, and it was really through a survey that we found Ricky. And then Ricky is just superstar and is very committed to this. So one thing that has changed is with Sandy leaving, we had real resource issues when it came to HRA. And so we had that only low grade dysplasia was going to GI, and all high grade dysplasia was going to Sandy and the colorectal surgery team. But now we'll have to change. We have that built into our referrals, our Bartlett referrals, but we'll have to change that so that now all level of anal dysplasia will go to Green Spring, to the GI team. And I guess, and we have to reconvene, I think, because if Ricky is going to Jayhawk, how on the back end would that get sorted out?
Right. Yeah, so that's not clear.
To have this expertise and this resource here. So thank you.
Yeah, thank you, Joy. So I think the plan is that, Maaza and Bridget will build, their own clinic in the fall, and then, we offer also more clinics. And then, whether I go and see, twice per month patients within the surgery Jayhawk clinic just to offer, the vicinity for our patients there, that remains to be determined, but might be a possibility depending on the, relationship with the surgeons. But we also work with, Dr. Atala already to make sure we have that, kind of the connections and the collaboration with the surgeons, because that's very important. And, even if Sandy doesn't have her practice there, that we, there are certain issues where we definitely need a surgeon. And then, as Maaza, I think, mentioned, I really hope that we're going to get the HPV 16-18 screening, I have to follow up with the microbiology lab. And I think that would also make it, it's good for you guys on your end too, when you do the anal pap and you're going to get the HPV 16-18. And then we could also see, whether we can come up with a better kind of, algorithm, depending on HPV 16-18 data. I really think that the data are there and we should just have that. And yeah, I hope we make that happen within the next couple of months as well.
And that would be automatic, Ricky. We don't need to order that special. So once we do the anal dysplasia or the anal pap,
right,
that will be an automatic test that's done.
Yeah, I think they haven't built the EPIC, order for that. That the one issue is, the microbiology lab, they have to do that, the order and the validation. And what I haven't completely figured out, somehow I'm a little bit stuck there, is figuring out to make sure that this is being paid for our patients, so they don't get the bill. We have our colleagues in Washington, who do that, and they have good experience, but it might obviously be different for the patient population that we are serving in terms of insurance coverage. But I think it's really needed. So I am glad that the lab is working with us so we can finally pull that through.
There's a question in the chat from Meredith Soltic. And so based on the research, are we able to offer safe self-anal pap collection, or are we not there yet?
We're definitely not there yet, but Ricky and I are both very interested in point of care testing. So it's something that we want to study for the future, but we're not there yet for sure. We tried to collaborate with one of our basic scientists too, but it's something we'll think about for the future. But I think just with COVID and barriers in care in other countries, it's just been more of a topic this year.
I mean, it's interesting because in Miami about 10 years ago, there was an initiative to do self-collected vaginal paps actually in the Haitian community in Little Haiti who had barriers to accessing care, and that seemed to work pretty well. So it's interesting that that continues. I think one thing your presentation has really highlighted for me is how we are really on the, we're at a stage where research and data are still so preliminary in this particular space.
Yes.
And it's exciting that we can all be a part of it and see all of your efforts come to fruition. But
We certainly
when
want
will
to
the trial that you discussed, Maaza, be the one that is looking at outcomes? When do you think that trial will have data to share?
for which one? For
The
HPV?
anchor.
For Anchor. Oh gosh.
I think
with COVID, right? They had a big delay.
right, they have a delay, and then the other, so I think they have a follow-up of 5 years, so they're not fully enrolled. So it's really, you know, it's still gonna be, you know, a while. So I don't think it's gonna be before the mid of the 2020s or even the later half of the 2020s, unfortunately. I know that there will be probably, you know, a lot of information. I know there's sampling a lot of studies, and they're going to look at a lot of different, you know, markers that can also probably help to identify better biomarkers in the future. But I think that is still a little bit in the future. I don't think we can wait, you know, obviously. I mean, there are people who say they want to wait because, you know, they want to have their real randomized controlled evidence, but I don't think that's the pathway.
I imagine just from in terms of getting Medicare and Medicaid to pay for things like this, it's difficult without the trials and
But they do pay.
They do.
They do pay for, and I mean, I don't think it's an issue. And I mean, you are anyway serving highest risk patients, right? So.
yeah. Joyce is asking, will you continue the artesunate study that Sandy started?
Oh goodness. So I think so I'm hoping to collaborate with that in the future. I know that I think that the maker of artesunate is in the Cleveland area, and so I think Sandy and Michelle Inkster are going to be working on that, and maybe when Sandy leaves, Michelle will take over. But I'm trying to to broach into that area. So Sandy's working on it.
So the phase 1 that Sandy did is concluded. So I think they are analyzing the data, and you know, then we will see whether the outcome is. So for those of you who don't know that interesting study, it's artesunate intraanally, which might have an antiviral effect on HPV. And Sandy, you know, did that and followed people with high-grade dysplasia and who took the intraanal artesunate, you know, followed them with regular HPV DNA testing, and then also HRAs to see what happens to the high-grade lesions. And there was a previous study that was actually done by Connie Trimble for cervical CIN here at Hopkins, and then, you know, Sandy took that and applied to anal. So I think they're finishing the analysis of the phase 1 study.
The phase 2.
Anecdotally, I have a patient that Dr. Trimble follows for VIN, and she's had treatment with artesunate with really, really great success. And I think Sandy has also talked clinically about her use of artesunate and how successful that's been for some of her patients. So it's kind of exciting.
Other questions folks have for the group?
I think antivirals for HPV is really something that each of us wants, right? And explaining to patients that we don't have an antiviral for HPV where we have one for HIV and hepatitis C and everything is really sometimes not easy. So hope there's something.
And I know, have you worked or have you interacted at all with ENT, just in terms of,
Head and neck cancers?
Yes. Yes, and just again, the theme of HPV
Right.
in all of the places. Just wondering if you've had a chance to interact with that group also.
Not yet, but I know that the head and neck team, they actually have a dedicated kind of center and a dedicated person for the HPV head and neck issues. So we should probably find some time and reach out. I mean there are some differences between the head and neck and the anogenital lesions, just in terms of known kind of precursors and the dysplasia. But I think it would be definitely interesting, and since obviously there's a lot that is also in common.
And Ricky, is there any data on the impact of vaccine on head and neck cancers? Is there any information on that?
So there is actually a study that is going on that is looking at persistent infections in the oropharynx, after vaccination, but it's more difficult to evaluate that, obviously, because the kind of dysplastic lesions are not necessarily identifiable in the head and neck. I mean, I think there is obviously no reason to believe that it would not be effective if you haven't been infected before, right? So in the long run, with good HPV vaccine uptake in the young population before they get exposed, I think that that trend of the increase of HPV head and neck cancers may very well also be reversed again. But
I think David has a question. Dave, did you have some?
Yeah, I did. Thanks for the talk. I stepped away for a minute, so I apologize if you addressed this, but I take care of a lot of younger patients. And so I appreciate you with the New York State guidelines with that age 35. I struggle with when to start screening, and so we have some perinatal HIV patients who have kind of longstanding disease, or HIV patients diagnosed in their teens who are now kind of in their approaching 30. And just your thoughts on kind of age and screening and how that factors in. I know there's probably not much data, but I'd appreciate your thoughts.
So, it's a good question. And years back when I started, that practice, I asked actually Dr. Palevsky, and he was thinking about 30. I actually have not reviewed, I don't know entirely why New York State says 35. I mean, it's not exactly the same as in cervical cancer, and we just don't know enough, I think. I mean, yes, do we see cancer, under the age of 30? Maybe not, but definitely we see, high-grade dysplasia. So, I mean, we haven't really done that, and we see a lot of patients in their 20s. And thank you also, David, for referring a lot of patients to us. We see a lot of your patients.
Well, that's my question. Should I stop referring them to you?
Actually, I'm very happy also to go. I have to go to that, to some of the literature. I mean, I would not necessarily recommend that. I think that, especially in the young population, I think that there's also a lot of education that we can do. We can also address, for example, the HPV vaccination part and STD screening and stuff. I know that, most of you are very good also with this, but not everybody we're seeing here, has providers who are also paying attention to those kind of things. So, I mean, I could not necessarily say why I would recommend an age cutoff of 35. I've definitely seen a lot of pathology under the age of 35.
Other questions?
Maybe, going back to that EMR, Natasha and Joyce, do you think that having some kind of EMR reminder, Joyce, as Dr. Inkster had said that they have an Epic, is that something we should look at? Would that help you guys in the clinic?
It might be interesting to get Steve's thoughts about the GCCT reminders that he built into Epic some years ago, and if he thought that because I think initially it was helpful, and then I think in informal discussions, I think he was saying that people started looking at it less. So I don't know.
Yeah. I'm sure they ignored it for a
I
while.
don't know what your thoughts are, Joyce, about that.
Yeah, I mean, I think we could consider integrating, I mean, there are best practice alerts that are in the system that could identify the people who need, you're thinking about which aspect? Anal PAP, HRA?
No, anal PAP. Or
Or
reminders for sending them back or something like that to us.
Yeah. I mean, it's something, I guess one of the reasons I hesitate to some degree is it is shared decision-making, right? And it is sort of, we are waiting for the anchor study. I mean, obviously, we all think we feel comfortable to extrapolate, from cervical cancer screening to screening to prevent anal cancer. But I guess maybe Maaza and Ricky, you could give your thoughts about that, right? So, and just so that you all know, two of our fellows, Stella and Sonia, are working on a project to look at how well we're doing anal PAPs among same gender loving men living with HIV in our clinic. And then if they are abnormal, how well we're making the referrals, and then how, what's our completion rate. So that'll be very helpful and could inform this. But maybe Ricky and Maaza, what's your take on, I guess I think I know the answer, but based on the data we have, how much should we be being diligent about this in our population?
Well, you guys have people living with HIV, so that is the highest risk. I mean, that's a 50-fold increased incidence in the development of cancer. Although rectal cancer overall is low, and that's why there are really screening programs. I think it's very warranted.
I mean,
what do you think,
Joyce? You point out, obviously, every cancer screening, I think, is shared decision making, right? Even colonoscopy or breast cancer screening, should be, something that the patient also sees the benefit, because we all know that there is a risk of over screening, and, the discussion on the harm through over screening and over diagnosis has, I think, been discussed also in the media, over the last couple of years, and has affected breast cancer and prostate cancer, obviously. So I do think that the patient have to understand and make a decision for themselves that that's what they want. Oftentimes, obviously, it's very complex. So that's why I think that's also a process. They may come to us, and then, this is an ongoing process about their thoughts on whether this makes sense for them in the long run, or whether that is something, they may want to do kind of once and then never again, because they don't see that it makes sense for them, right? So I think there must be an ongoing discussion on that, especially for those that are returning. I think there are some data also that show that, screening can lead to earlier detection and may have an impact on, on anal cancer incidence. Obviously, it's very difficult, as you all know, to get good data on that. We've been struggling with other cancers that had, like breast cancer started screening decades ago, and still we are not sure what exactly the impact is on mortality, right? With all adjusting for all kind of biases there. I do think that we see patients here that, are really kind of, we see a lot of patients who appreciate it. And it's also, we have very good show rates, because I think that patients actually, they kind of are really happy to come to a place where they, that whole anal thing can be addressed. And oftentimes, oftentimes we get a feeling whether somebody has a real issue that needs to be followed up in the long run, or whether they are just good to go. And I think that the 16, 18 HPV screening may help us to also kind of tailor that a little bit more to patients who don't need long-term, surveillance or testing. So yeah, I mean, obviously, I wouldn't be doing it if I would not see any meaning in it, right? But yes, every patient needs to determine their own goals for their care, and we can only support them in what they wish for their health.
One last question, because I know we're running short on time, but Matthew was just pointing out, is it possible for folks who haven't had their gonorrhea and chlamydia screening, if they come to HRA clinic,
Yes.
is it possible for them to have it done at that time?
Yes.
We offer it routinely to anybody. So yeah, so if you know that they're coming, we can also just do it. So we offer it routinely.
That's perfect. Thank you, Matthew, for bringing that up. Well, I know we're at time and I know you all are at clinic, but thank you. I'm really excited about this as a resource. I've been in the clinic long enough to remember that having to refer out to a provider out in the community who had, variable communication skills. And so it's really wonderful that this comprehensive multidisciplinary clinic is a resource for us. And we're very lucky because most places in the country, I think, as we all know, don't have access, this kind of access. And it's exciting to hear about all the potential research that'll come out of it as well. So thank you so much for updating us and sharing information about the clinic with us. And again, very lucky.
Thank you.
Thank you.
Everyone, have a good weekend.
You too.
Thanks.
Bye.
Bye, Joy.
Thank you for your help.
You were in time. That was awesome. Lots of time for discussion.
I don't, cutting everything.